Good evening. Uh, After a successful All India Ophthalmological Society program, I think we all are very happy and contented as an initial phase. But again, that was primary task for WSWB to make it successful, and probably we are actually did it. But again, then the next job is again to take care of the academic part of WSWB, which cannot be ignored at all. So next, what we thought as initially after this is beginning with the bedside clinic. So a lot of theoretical discussion was there. We will straightaway move to the different cases of all the specialties. We have divided into 5 cases of anti-segment and 5 posterior-segment cases together. So without any delay, we will just move on for the first session of today's evening. And as a customary, we will, we need to do the garland for running for our president. And as Dr. Devdas Mukherjee could not be here, so our president-elect, Dr. Arup Chakraborty sir, if you can just be on the stage, please. Now, as it is a working day evening, so it was little difficult for all of us to reach at proper time. So Dr. Sugato Paul, moderator of this session, could not reach. So I will, do his job till he reaches here. Can I request our chairperson, Dr. Yasin sir? Sir, please be in front, and Dr. Parag Mukhopadhyay sir, please. And we'll request our panelist, Dr. Arup Chakraborty is already here, Dr. Saurabh Sannal, Dr. Rajesh Majumdar Chaudhary, Dr. Amitav Kumar, Dr. Maitreyi Das, Dr. Soubhik Banerjee, and Dr. Arup Bhaumik to be here. And I'll request Dr. Nilay Majumdar also to join in this panel as an expert for this. And there are little changes of, as presented as they are reaching as per. So we will start with our case number 4 with Dr. Surbhi. Dr. Surbhi, please start your case, Battling the Inferno.
Good evening, everyone. So I'll be presenting the first case. She's a 63-year-old female. She presented with the swelling of right eye along with redness and diminution of vision for a duration of 3 weeks. There was no history of fever or trauma. She is non-diabetic and non-hypertensive. On examination, at presentation, her visual acuity was hand movement close to face. She presented with proptosis, ptosis, severe restriction of ocular movements. On anterior segment evaluation, she had chemosis, corneal edema, shallow anterior chambers, grade 2+ cells and flare. The pupils were mid-dilated fixed, and the fundus details were not clear because of the corneal edema. The glow was dull. The intraocular pressures were 53. This is the image showing the severe restriction of ocular movements in all gazes. The gonioscopy showed closed angles in the right eye, but the left eye, the angles were open. The left eye otherwise was unremarkable with a visual acuity of 6/9 and the intraocular pressures were 17. On further investigating, the B scan showed a T sign in the right eye along with diffuse thickening of the retinochoroid sclera complex, and there was exudative retinal detachment seen. So a provisional diagnosis of anterior non-specific orbital inflammatory disease was made, and she was treated for the acute angle closure attack, as well as oral Visolone 60 mg was started, and she was asked to review with a CT scan. So on CT scan, so these hyperdense fuzziness was seen around the ocular coats. There was involvement of the muscle. There was also involvement of the lacrimal gland. This is the coronal section. So the hyperdensity is seen all around the globe. There is also presence of left side maxillary sinusitis. So then she was treated with IV methylprednisolone 1 gram for 3 days, along with oral steroids 70 milligram once a day, and followed by weekly tapering. She was also treated with topical medications, atropine, Gatalox, and anti-glaucoma medications. So this is her disease course since then. At presentation, she was given IV methylprednisolone 1 gram 3 doses, after which her vision first improved from hand movement to 660. The IOP improved from 53, but it was always in the range of 25 to 30. There was improvement in chemosis and ocular movements, and the exudative RD had settled. But there was persistence of subtenon fluid, so she received another IV methylprednisolone in May. Then she was followed up with the oral course of steroids and tapering dose. In June, the oral course of steroid was completed, but there was persistence of subtenon fluid, so she received an injection of posterior tricot. Then in July, August, and September, she again came back with recurrences. So again, IV methylprednisolone 1 gram had to be used. Meanwhile, her intraocular pressures were not under control, and her cup disc ratio had increased to 0.6. In October, after rheumatology consultation, she was started on mycophenolate mofetil 2 grams. The vision, she was maintaining a vision of 618, but the intraocular pressures were still not under control. There was persistent flare in the anterior chamber and congestion, and the cup disc ratio had increased to 0.8. Then she was lost to follow-up in between for 2 months. In January, she came back with another recurrence when she was the rheumatologist advised an injection of adalimumab. So she has received 3 doses of adalimumab, 1 each in January, February, and March. And because of the uncontrolled glaucoma, she has also undergone a phacoemulsification with trabeculectomy. On the last follow-up, her vision is 612, but the intraocular pressures are still 24, and she is on brinzolamide and brimonidine combination. This is the image on last follow-up. So there is persistent ptosis, there is persistent proptosis, and the anterior chamber as of now is quiet, and she is due to receive her last dose of adalimumab in the next month. So I would like to invite Dr. Mukesh sir for the discussion of this case.
Thank you, Dr. Survi, for that challenging
How was systemic
case.
investigations?
Systemic investigation, she was worked up for the vasculitis panel, sir, ANA, ANCA, to rule out all the vaginous granulomatosis, SLEs. So all came back negative, sir. And the thyroid profile was also tested, that was also negative, sir.
Okay.
What was the intraocular pressure of the other eye, the status of the other eye after
The-
taking the systemic steroids?
She was not a steroid responder, ma'am. No, ma'am, it was normal.
Thank you, Dr. Survi, for that excellent presentation and this challenging case. So we can briefly discuss this case under this 5 headings, that is getting your diagnosis correct. We have the differential diagnosis for such cases is huge, and we need to have the whole battery of biochemistry, serology, and imaging done. Most importantly, we have to rule out any lymphoproliferative disorders and infections, that is orbital cellulitis. Once we can rule out this, most of the management will be for inflammatory conditions. Second, this case actually highlights the multidisciplinary approach that we have to work as a team and not as an individual department. Third, I feel that most of the recurrences were because we were tapering off the oral steroids very quickly. So we are scared of oral steroids. But actually, when we should use steroids, we should use them in the adequate doses and for the adequate time. And best is to rope in a rheumatologist so that he can start a immunomodulatory or biologics so that we can have the steroid sparing effect that we want. And be always open if you have any recurrences to revise your diagnosis. Because we may always be wrong sometimes because such diseases have a course which can actually change over time. And some eyes actually have a very aggressive course. We have to counsel them correctly and make them understand that they will require a longer follow-up, multiple treatments, so that they don't lose on follow-up. And once they lose on follow-up, when they come back, we have already lost the eye. So this importance of counseling, making them understand and having a proper consultation. If we are sending to the rheumatologist, we must write particularly what we want from him, rather than just writing it to the rheumatologist. We should consult with him, talk to him, discuss the case, so that he knows what his role is. And similarly, when the patient goes there, he is not in a fix that, he doesn't know anything about the case. So we have to play as a team so that we can help patients and we can save their visions. Thank you.
Actually, I was about to ask both Dr. Amitabh and Dr. Rajesh. So Amitabh deals with a lot of inflammatory condition and their steroid use is much prolonged. So what is your take at this point of time? And then Dr. Rajesh for how the orbital things to be managed.
Yeah, so nice case and pretty well managed. But I think the only two things which I would have done differently is I would not have given a posterior subtenons injection in this patient, number one. Number two, I would have topped her steroids with immunosuppressives pretty early in the course of the disease. So these are two things differently which I could have done. And yes, you did go up to biologics. So, but at this age, with all the other complications, I'm not really sure how she would have reacted to the immunosuppressives and the steroids. But I think for such cases, if you put them on steroid-sparing agents, especially at this age, I think that's a good idea.
Yeah, thank you for your points, Dr. Amitabh.
Great case, of course. My suggestion is that, if you look at the times scale of the various events which happened, and then we find that in April and May, she was having some recurrences. But you started her on mycophenolate in June. I think that is a bit of wasted opportunity. We have learned from the transplant, specialities that mycophenolate has got a very good, steroid sparing effect, and we have been using that in thyroid eye disease treatment for a long time now. So mycophenolate used in the proper dose can actually help to reduce these recurrences. Each recurrence is actually causing, tissue damage, and, all the spikes are causing troubles. So I would have, as Amitabh said, I would have started the mycophenolate pretty early on and continued for months because we know that it's a safe medication.
Amitabh, why would you like to not take an PST for, what was the thought process behind not giving a PST?
She already had a glaucoma. And the PST, if it goes into the posterior subtenon space, you cannot undo it. That is number one. And number two, the eye was so inflamed. I think PST, because it's such a blind procedure, you don't know where you're going. So I think instead of a PST, you could have delayed the PST for much later. But if you had started this patient on, probably tapered the steroids slightly slowly, and as Dr. RMC also said, if you had added the immunosuppressives much earlier. So initially when mycophenolate was not available and it was very, very costly, we used to put these patients on azathioprine. But nowadays, because of a better safety profile, I have almost completely switched over to mycophenolate as compared to azathioprine. Plus, we do not do TPMT for all these patients, so we don't really know how will be the patient's response to the azathioprine. So mycophenolate does well. The only thing is it is a bit costly.
Not really. Not anymore, actually. There are a lot of local brands of mycophenolate, and it has been used extensively, as I said, the transplant surgeons. And in thyroid eye disease, if you look at the latest recommendations by the UGOGO team, mycophenolate is actually the most important medication apart from the steroids. And as I said, you can use them for months and months, not a problem at all.
Can I ask you a question?
Yeah, sure.
If you are asked that what is the diagnosis in this case, okay? It's an inflammatory disease. I think it started off with a scleritis and it has an autoimmune basis to it, right? So if you are asked what is the diagnosis, I mean, they've said about the treatment, what would you say the diagnosis was?
Since the workup was negative, it should be known as idiopathic inflammatory orbital.
Sorry?
Idiopathic. It would be an idiopathic inflammation of the.
It looked as if it started off with a scleritis, basically. And it involves all the coats, as you know, and spreads. So basically, it's an autoimmune complex. Idiopathic, yeah, that's the autoimmune complex. I'm talking about the diagnosis. Would you say that if somebody like me, if it writes that query scleritis, okay? Because scleritis, when it's intense, gives rise to all this inflammation involving the coat, involving all the coats, and inflammation in the eye can give rise to rise of intraocular pressure. If somebody writes query scleritis, would you say that's a wrong diagnosis? What would be your diagnosis?
Yeah, do you like to answer? No, I think your point is absolutely, but it is sometimes, it is very precisely difficult to say. It can start, like in case of pseudotumor. So what do we get? Like most of the time, the systemic investigations are normal. But yes, the overall orbital inflammatory response can be as a presence of localized. Now the next question of continuation of this question, next question is that now this patient is negative. Now age of the patient is around 60. So it is difficult at the age of 60 after that to be positive for the collagen vascular disease to be positive. If it is a 40s or early 40s or even up to 50s, still would have been probably follow-up. But again, in future follow-up with the systemic diseases and with the rheumatologist, that is more important for this patient to develop other immunological disorders, whether they are developing or not. So I may be the actual, opening for the disease to get presented. Yes, I agree with you. It can be a part of the scleritis. Is absolutely okay. Scleritis with an orbital extension kind of thing. The only issue with only scleritis diagnosis, because here the involvement of the lacrimal gland is also there. So probably in that way, from the scleritis, the lacrimal gland going to is little difficult. It may be in the periocular space. So probably it has the involvement is probably into the concurrently with the orbital tissue as well as the ocular coats. Exactly.
I'm slightly concerned that at her age, we might miss on paraneoplastic syndromes as well. So that is actually a very important thing to remember. I would have probably got a tissue diagnosis from the lacrimal gland at some stage, just to understand what it is all about, because you haven't found anything yet. And that is one way of looking at it.
And they do respond pretty well with immunosuppressive and the steroid as well.
So any uveitis at the extremes of age should raise a red flag. You should be very, very careful with uveitis at the extremes of age. Primary uveitis occurring for the first time. You must keep masquerade in mind.
Can I ask one question? So this is the patient because of the component of uveitis, the intraocular pressure was not under good control. I have not seen any perimetry done. That should be done regularly, because sometimes, looking at the disease itself, okay, the pressure is 24 is fine, but how is the progression of the perimetry? Sometimes we get the patients, they do not do the intraocular pressure control that way good, and the progression goes on. Someone is controlling other things and intraocular pressure is not being addressed that way. So after trabeculectomy, I think the last pressure was 24 with a combination of 2 drugs. So you could have done the trying some. I'm sorry?
Thank you. The patient was...
Yes, no. Earlier.
Actually,
How much earlier? How much early is earlier?
Actually, the patient had these attacks off and on. So this uveitis and other components, we did plan the full glaucoma workup, but couldn't do it. Number one, due to the disease coming and going, and the patient was also very apprehensive. Sometimes he didn't come, and the patient delayed the surgery for a long time due to apprehension. So, and later on the cataract developed, so we plan to do the perimetrian workup after the cataract surgery is done, but her disc changes were on regular follow-up.
Now yeah.
I'll be an imposter if I give too many opinions on uveitis case. But I can only tell you from my experience as an oculoplasty clinician dealing with thyroid eye disease, and I've seen, and the evidence is there, that in nowadays, mycophenolate is a very good steroid-sparing agent. So in this kind of situation, when I looked at the time scale of the various clinical events, I would have probably thought that using a steroid-sparing agent earlier on at a proper dosage would have been a bit more protective for the patient. That is my take.
You used it at the first recurrence.
Exactly.
At the first recurrence. So you start with steroid, then to mycophenolate. No, my point is that mycophenolate is a drug in the market for last 20 years. And it is one of the very important issue the same drug was launched and special ARVO session was there for mycophenolate. Dr. J.M. Thorne presented the paper. At the same time, at UK also the mycophenolate was in did much gullas with 4 specific indication. Uveitis, yes. Orbital inflammatory disease, yes. Scleritis, yes. These are the 3 as a steroid sparing agent. My point is that, so vis-a-vis, who will give the drug? You or the rheumatologist or the medicine specialist? Because as you have told, MMA 500 is selling like hotcake in India. But can you give that? Number 1 question. Yes, you can give that. So what is pros and cons of these versus IVMP? Why people are not giving MMF? This is my question.
Shobhikda, case
Okay.
present, we will have the continuation of the treatment. I think mycophenolate, mofetil, for uvea specialists, they are using on and off and very frequently. So this is what we can give it. This is one of the safest drug, probably the side effects.
Yes.
So Amitav can talk on this. But again, IVMP was given twice. I think IVMP was given for this patient, and after that also mycophenolate. So. Would you like to
last
comment?
Point. If you want to control the inflammation, what is your take on giving a small unit, say like 8 to 10 gray radiotherapy to the apex of the orbit? We have fantastic results.
No. Yeah.
Is the last resort actually, last thing. And radiotherapy, radiotherapy is not in our place. We are not very comfortable with the radiotherapy. That we give very infrequently, because you have.
Yeah, I think this is the debate will keep on going. But yes, the different modality. The most important is that the take-home message is that need to control and prolong and tight control of the inflammatory condition, and to have a very close look for the systemic any changes or systemic any development is occurring or not. And the glaucoma. Glaucoma is actually the secondary part of it, because this is the secondary glaucoma which is developing. Yes. So thank you. Yes. তুমি ছেড়ে দাও, তুমি শান্তনু মণ্ডল আর সৌমেন মণ্ডল আছে তোমার কাছে, তাদের দিয়ে ট্রিট করিয়ে নেবে। We will move on to no please we will move on to next case.
With us is a ocular problem. They are also waiting for that. They are giving even more than mycophenolate, and they are rituximab and all that drug.
We'll move on to our next case. I will request Dr. Ashish Majumdar to present his next case and take over by Dr. Sugata Paul. Please.
Very good evening to everyone. Today I am going to present an atypical conjunctival lesion as a first sign of PUK due to granulomatosis with polyangiitis. A 33-year-old male presented with a history of dimness of vision in the right eye for 3 weeks. With that, patient also have a history of photophobia, watering and discharge. He has presented with conjunctival reddish lesion in the inferior part of the bulbar conjunctiva in the right eye and associated with the diffuse conjunctival injection in the lower part. Patient has a progressively increasing mass for last 2 months, and there is also history of exacerbation of the same episode for thrice in 2 months, and also gave a history of flu-like syndrome and polyarthralgia. Patient previously has been seen by many other ophthalmologists, and they were treated him as an OSSN or simleferon in some place also. The picture looks like this. There is a boggy mass in the lower conjunctival, bulbar conjunctiva with shortening of the lower fornix. The ocular symptoms were eye pain, visual impairment, hyperemia, eye discharge. There was no corneal ulcer. Peripheral ulcerative keratitis was there, and scleritis, episcleritis and conjunctivitis was there, but no retinitis, no uveitis. Pupil was normally reacting to light. If you see the orbital signs, there is no prominent orbital signs like proptosis, xanthelisma, eyelid edema, ptosis, or diplopia. So I was in a dilemma when the patient first came to me, and then I didn't understand what to do, but I somehow felt this is not OSSN, because OSSN pictures looks in a different way. Patient first day when he came to me, he said that I was treated like a cancer in my eye and I am very scared. After seeing this picture, I was sure that this is not OSSN. So I took some other histories, especially systemic histories, like whether there is any weight loss. Patient says that yes, I have started losing weight, but there was no significant decrease in the weight. I asked for the headache history. He said that there is some intermittent pain when I work a lot, but there is no persistent history. Here persistent pain is important. I asked for any other involvement such as genitourinary involvement. Patient said that there is no history of such that, but there are 2 times of balanitis in last 6 months. Then I asked for whether there is any history of pulmonary involvement, any headache, dizziness, any ENT involvement, or any other cardiac problem, whether he has or not, to rule out whether that patient has any systemic disease or not. Then I have gone through his posterior segment analysis. The posterior fundus was clear, OCT is normal, USG also shows normal. I wanted to see USG to see whether there is any choroidal pathologies present or not. So there was nothing what I have seen. But in the first day when he came to me, I did anterior segment OCT and I saw lower part of the cornea shows a thinning of 566 micron. Whereas in the side of that picture, after 28 days, it rapidly progressed into 300 micron. I'll come to this later on. So before proceeding that, I started that patient, as he came to the OPD, I started that patient on amoxicillin and dexamethasone eye drop, and I gave some lubricant and I sent him away. Because I had no idea what is that patient. I started studying about that patient, what to do and what not to do. I talked with many other ophthalmologists and they suggested do a histopathology. So I took a piece of that conjunctival lesion and did the histopathology, and that histopathology shows a granulomatous lesion in the conjunctiva with leukocytic infiltration. And in the 200X you can see there is the limbal infiltration of the leukocytes. So that is the actual cause of doing the PUK. And when that patient had undergone CD68 immunohistopathology, that came to, that shows that histiocytes and giant cells over there. And they have suggested some other immunohistopathologies also, immunohistochemistries, but the patient was not well to do and he was not ready for paying more money. So from here, the pathology is diagnosed as it is a GPA case. So further I went on doing, in the meantime also I have done the complete hemogram and the urine analysis and serological test also. All are in the same time I have given to that patient. Hemogram was normal in limit, but urine analysis shows that there is raised creatinine level. There, the color of the urine was yellow, pale yellow, which is foamy and hazy in nature. Specific gravity was increased. There is significant amount of RBC cells and casts, and urine protein was positive. So then and there I was sure that this patient might have any kidney involvement. And also the serology shows that that patient has raised CRP and P-ANCA is positive, whereas C-ANCA is negative. So from that all picture came around that this patient has GPA. So at that point of time, I referred that patient to the rheumatologist and the nephrologist. I had no idea what to do about that. So we collaborated in the medical college. I have talked on rheumatologists in the medicine department, the nephrologist in our medical college. So they took up the case and they did the other tests where they have done the chest X-ray, which was normal. There was HRCT, which was normal. Even the ENT came into the part. They have done the MRI. The T1 shows the normal PNS. T2 also shows the normal PNS. So there is no other systemic involvement except kidney. This is a taken picture from a book, from a journal. The nephrologist says that this patient has the pauci-immune crescentic glomerulonephritis, which is basically a Hebrew to me. I don't know what is that. So this is the diagnosis. So that patient has been taken by the nephrologist and the rheumatologist. So what I have done as an ophthalmologist, I have started that patient on moxifloxacin, prednisolone and lubricant in the first visit. But when the patient came to me after 2 weeks, there was no improvement in the result. So at that time, I added oral prednisolone to that patient. I also asked that patient to get admitted, and that time I would have started IV methylprednisolone, but the patient was very much apprehensive. He didn't get admitted. So in meantime, the histology came, the other reports came. So that patient has been taken by the nephrologist, and they started rituximab by Rituxan protocol. Now coming to the point why they have started rituximab, there is a treatment. There are two types of treatment in these cases. One is cyclophosphamide, another option is rituximab. Now when we three sat together, and this is the post 6 months result after the rituximab, and there is a significant improvement and there is no further thinning of the cornea. Now, in the discussion part, I want to say that there are two types of AAVs, that is the ANCA associated vasculitis, that is P ANCA positive and C ANCA positive. The C ANCA positives are most commonly notorious for the scleritis part, and most commonly seen in the most common seen ocular pathology is scleritis. But P ANCA shows less common ocular pathologies, but their prognosis is worse than C ANCA positive. And in this chart you can see if the P ANCA positives are more commonly having the renal problems. So this patient has undergone rituximab, whereas there is a study had gone previously where they have shown that rituximab achieved the higher rate of corneal PUK prophylaxis than the cyclophosphamide. Whereas there are few studies or cases has been done where they have shown that the same patient, like the PUK have happened to them, they had first took the cyclophosphamide at the first line drug, but PUK has not been, PUK is get progressed. So they had to shift it to rituximab. So instead of we started doing cyclophosphamide, we started doing rituximab. But at the same point, that patient also have the glomerulonephritis. So according to the RituxVAS trial, they showed that there is no significant difference between the cyclophosphamide and the rituximab. So in all point of view, rituximab was win-win.
I understand, but again, this is going beyond the purview of ophthalmologist. So let us concentrate on what is needed for our clinical practice. So this is a case which you have shown, which has presented atypically with a kind of a lower part of the conjunctiva is bulged out, and there was an inflammatory condition, which is no doubt. And you did, patient was with topical, it was not responding. So you did histopathology, which is absolutely justified to do it. whether anybody would have been differently treating as an initial. He thought of something else and he did of histopathology first, which actually has guided him. So suppose a general ophthalmologist who has not done the histopathology as the initial phase, so what would be the course of treatment or how to proceed about it? Dr. Mrinal Kanti Ghosh, I can see Mrinalda. So ophthalmologist and pathologist together. So how would be your take home? Can you just comment on this?
I fully agree with Ashish. The wonderful presentation and also the way he managed should be a prototype of these types of cases. Thanks.
So any specific?
Yes, there is a point I forgot to tell, that I have thought of giving doxycycline to that patient, but patient has given me a history of having diarrhea after taking doxycycline previously, as the patient was previously been treated by other ophthalmologists who has treated him as an OSSN, and that patient was also treated by him with doxycycline, and that time that patient has diarrhea, so I stopped that. I didn't give the doxycycline in that case.
So the take-home message probably when it is not responding kind of scleritis or a semi-orbital lesion involving the ocular coats. So did you did any MRI or anything else before going before histopathology?
No, I have actually sent the patient for everything together.
Okay.
The MRI, the CT scan, the hemogram, the histopathology, all together. Pardon, sir?
Blood, hemogram and the urine analysis before biopsy or after
So the
biopsy?
result of the hemogram and
Came after biopsy.
came before the biopsy.
Oh, came before the biopsy.
The biopsy report came later on, actually.
And what was the ESR of these patients?
ESR was
normal.
ESR was within normal limits. Okay. Right now, I am being follow-upping this patient for 8 months.
You see, there is quite a lot of symblepharon coming up. With the scarring, the symblepharon is going to increase. So that you should keep an eye on that, isn't it? As the disease settles down, the complication of the disease would be the symblepharon and what other problem it is doing. So that is important because it's going to...
I have planned for this patient to release the symblepharon and to put umbilical cord patch graft over the thinned out cornea. No, not right now, ma'am. In the future, I have planned to give umbilical cord patch graft to this patient. That will give some added thickness to the cornea.
No, there are only 3 points. One important point. What Ashish has presented with it's a...
I think this is OSSN, but where is the PUK mark? Peripheral ulcerative keratitis issue. Do show, please.
Sir,
Which part?
you can see there is symblepharon is going upstairs.
Right.
But when you do the slit lamp or the ASOCT, then you can see that, let me show you the ASOCT picture. Here you can see
prior to ASOCT.
Sir, the OPD that patient has come on that day I had done the ASOCT. I have seen it in the slit lamp and also done the ASOCT on the same day.
He has documented corneal thinning by ASOCT, even by the slit lamp also.
Even slit lamp can...
Even slit lamp also can show...
You can see that thinning.
Quick comment.
There are 3 points.
শৌভিকদা তুমি এবার তোমাকে কেন বলতে দিচ্ছি
ফার্স্ট অফ অল তুমি যে ছবিটা তুলেছো ওটা লোয়ালটি টেনে এনিবডি হুইচ ইজ ট্রিটিং দিস পেশেন্ট অ্যাজ এ সিমলিফেরন ইজ কোয়াইট অ্যাটিপিক্যাল এটা দেখে মনে হচ্ছে না The second very important point is that you have done an ASOCT, but what about the UVM?
The UVM is not present, sir.
UVM is not there in RIO, sir?
No, sir. UVM is not present.
So that's a take-home message, RIO doesn't have any UVM. The second point. The second, second important point is that it is not your purview, but to prove it, it is a worldwide known.
তুমি চা খেতে যাও
যা ছিল
তুমি চা খেতে যাও
ওয়েগনারস গ্রানুলোমাটোসিস সেটাই চেঞ্জ করে নামটা এটা হয়েছে তো ফর দ্য ডায়াগনোসিস granulomatous inflammation of the respiratory tract is a must.
Pardon, sir?
देना.
Granulomatous inflammation of the middle size bronchus or the respiratory tract is a must.
Sir, not necessarily as per the CHCC
No, sir, you go by the definition. Read definition.
সৌভিকদা ওটা আমাদের কাজ না এখানকার ব্রঙ্কিয়াল বায়োপসি নেবে কি নেবে সেটা ওরা বুঝে নেবে see the most that's what like most important is that presentation with this kind of the purpose of today's program is presentation of this kind of presentation which is non-responding to your standard treatment.
yeah.
Probably you need to think in a
Did you
different
go for
way.
the interleukin measurement? IL-17, IL-13, CD.
I don't know where these are done.
Great presentation, Ashish. Great presentation.
আমাদের হেডেক না ওটা
Rupak,
Okay, thank you.
Rupak, for
Thank
a
you.
general ophthalmologist, if you get a case like this, what ideally you should do? Should you refer to
Refer to Ashish.
refer to an institution?
No.
or-
That see what Ashish from what we have learned from this case is if you have given normally আমরা কি শুরু করব একটা টপিক্যাল স্টেরয়েড একটা লুব্রিকেশন আর একটা অ্যান্টিবায়োটিক ম্যাক্সিমাম সো ইফ ইট ইজ নট রেসপন্ডিং আফটার আ অ্যাডিকুয়েট টাইম ফর 7 days or 10 days time if you think that it is not responding properly probably it is a rethink and take home message from this case that you should whether other investigation or histopathology can give you a next guidance for diagnosing the case and redirecting them at a proper channel. So
See,
that's what is
Ashish-
probably the take home message for
Ashish,
today's case.
Just one thing I just want to say. In this type of cases, you should not actually give any topical steroid. You should not. Topical steroid is strictly no. The Symbleferon actually has saved the eye. It has saved the eye. Will be better if you start these type of cases with pulse steroid. And then if the patient cannot maintain or tolerate the steroid for a long term, then you can go to rituximab or other drugs. Rituximab is a quite well tolerated drug, but it takes a time to start acting. At least 4 to 6 weeks it will start. So it is better to start with pulse steroid. If the patient improves, then you gradually.
Thank you, Chandranadi, for your inputs.
Thank you.
Mrinmoy,
This case supposed to be present by Dr. Minmoy Das, but he's not here, and he sent just now the video over WeTransfer. I'm just showing this. I am seeing this video. He told me this is a case of a pediatric case, 10 years old, 15 years old, and the IL came to him as a dislocated IL. This is the scenario. He took this case into the OT for IL explantation. And there is a, over telephone, as he said, this is a PMMA lens. The lens was put in the sulcus in a young patient. So naturally what happened, this is a extreme fibrosis, and there is some kind of zonular dialysis in the lower part also. Probably this was a traumatic cataract of the child, I don't know actual case. This is zonular dialysis, and the lens was sulcus and the lens was dislocated. So naturally you have to remove this case because one haptic was into the anterior chamber, and he make a 6 millimeter incision, scleral tunnel. It is the best way to remove the PMMA lens, rigid lens, not going for the corneal tunnel. It's a make a scleral tunnel, and he just removed the lens. Now, who planned for the secondary PCIL? So Shobhikda, I just want to ask you. So. What to do this case, this type of cases? That one case, one side is a zonular dialysis. Now you have to give the secondary IL. What lens you will prefer? Definitely multi-piece foldable lens or any multi-piece lens will be preferred. So would you put the lens in the sulcus again?
The IOL couldn't be repositioned?
No, because the haptic one is rigid lens, one haptic is in the anterior chamber.
Yes.
And you can reposition. Yes, you can reposition, you could keep this lens into the sulcus. But again, the chances of extreme fibrosis, chances of dislocation again can
No,
happen.
but if you are thinking of putting a multi-piece IOL in the sulcus, in the same way you can keep the
And
PMMA
that's why,
lens.
do you have any other idea to put the lens into the sulcus? Yeah, see, fibrosis in a young patient, 15, that going to happen. That will every year there kind of some
fibrosis
kind of
is already settled.
Yes.
It's not going
So What
Yeah.
I would have
So probably-
these cases just
Yeah.
like this, remove the case. He just took the vitrector and make a PC rent there.
Yes, and
Uh,
capture the
yes, this should be the ideal procedure, and you can in that case he just make a slight little bit a smaller one. I could do that much bigger one or the oblique one too, because this case the lens capsule is very elastic. So either it is very difficult to capture the lens or the rexis elastic part may extend. So I could have do a much bigger PCR with the vitrectomy, make a posterior capsulotomy with the vitrector, so that I can easily put the lens into capture the lens. This is, you can see how he captured the lens. Now you just wait that he is struggling to capture the lower part. So if you make a slightly bigger, or it is make a oblique for PCIL. If you see the Karanjit Singh video, this is the Daljit Singh son, he always do the oblique rexis for the PPC. In case it is PCR, it is always easy to capture the multi-PCIL. So he make a smaller, but it's an oblique one. In that case, he also make a, but lens is captured, it will well settled, but as you can see this, this part of the capsule is maybe into the pupillary axis later on. So I could have do the much bigger one, so that the at least 5 millimeter for the 6 millimeter optic. So this is
there was
in my
no
case.
vitreous, no?
I think Konta. No, this is axis of multipiece. Chalo cha khabo.
Or there was no vitreous in the AC in the beginning?
No. Only there is a, you can see that this is a jonular dialysis, this part. See, there is a cluster of, as the lens was the previous lens of the anterior sulcus, there is a cluster of anterior capsule and posterior capsule. There is only one membrane. There is no separate anterior capsule or posterior capsule. See, he removed the central part of the membrane.
Now that's okay. What I mean to say, if you damage that part and pushing something behind that, later on that will induce a fibrosis. Again, there will be a contracture, and what happened to the IOL we do not know in the later on.
In that case, I
so why not go for a removal of the bag and a secondary IOL like SFIL? Why not?
That removal of the bag and fixing the IOL in the sclera in the pediatric case or the young child, I think this is a much better procedure.
Much better
procedure doing scleral fixation lens in. That is more extensive, and either glued IOL or you sutured scleral fixation, all have a limitation, you know. This is a much better.
So again,
but yes.
Arup, would you have taken the IOL out if you were doing the case, or repositioned and optic captured there?
No, this is a PMMA lens. I'll remove the lens because it's a very difficult. The old PMMA lens, it is very difficult because there is no angulation. It's very difficult to do the capture in PMMA lens. It is next to impossible. And one thing, very old PMMA lens, there is a chance of breaking. You know, if the slightest manipulation, there is a break in the optic haptic junction.
তোমার কোটা
তোমার তো ছোটই থাকে বড় হয়ে যায় পরে বলো
My question is only two. So, what you prefer here, Sensor AR40E versus Acrosop single piece?
Sensor AR40.
See,
AR40 is it's almost a side saver.
By any chance, this lens to be captured and the optics behind the posterior capsule, in that case, sensor multipiece or Acrosop multipiece works later, equally good. But if in any case, I have to put the lens in the sulcus without doing capture, I'll always prefer sensor multi, because the opti edge, the rounded edge, would prevent the rubbing of because the Acrosop has a sharp anterior surface.
And sensor is the purest form.
Thank you.
সৌরভ দা যেটা বলেছে
call the
last
next
answer
speaker.
দিয়ে দাও.
Yeah, we'll just.
Why not single piece with optic capture?
Showing the. এবার চা খেতে সত্যি চা খেতে নিয়ে যাও।
Capture.
Thank you. I mean, this is a nice way of showing cases that yes, even in difficult situation also, a simple manipulation can save your skin in a much better way. So that's what is the primary aim of this today's program. We'll move on to next presentation by Dr. Sipra Burman.
Good evening, everyone. Today, I would like to present a case of unilateral proptosis due to sinonasal mass. A 64 years of female housewife came to our IOPD with the complaint of right eye swelling with diminished vision for 7 days, which is sudden in onset, painless, rapidly progressive in nature. There is no history of diplopia or photophobia. It is associated with bilateral nasal obstruction for 1 year, which is insidious in onset, progressive in nature. There is dryness of the nose and reduced smell sensation, and nasal discharge for 3 months. The sensation of heaviness and fullness of cheek for last 15 days. The patient has been initially managed elsewhere but did not continue the treatment. She is a known hypothyroid, hypertensive and diabetic patient and was under medication. She took some homeopathic medication for the nasal symptoms. She had bilateral cataract surgery 3 years ago. And other histories are nothing significant. On to the examination of the patient, she is alert, conscious, cooperative, oriented to time, place, and person. Her vitals are within normal limit, and the systemic examination reveals no abnormality, except the cranial nerve examination, which is impaired on the right side, that is cranial nerve 1, 2, 3, 4, and 6. And local examination of the nose, throat, and the ear was done by our ENT department. In the nose, we found a thick mucoid secretion in the bilateral nasal cavity, and in the anterior rhinoscopy, it shows a polypoid mass filling the right nasal cavity, and there is gross DNS to the right. The throat and the ear examination reveals no abnormality. In the ocular examination of the patient, we can see the facial asymmetry, and there is unilateral protrusion of the right eye with swelling of the right upper eyelid, chemosis and congestion of lower bulbar conjunctiva. Palpebral fissure height was 15 millimeter, and the distance between the lateral orbital rim and the corneal apex was about 24 millimeter. Lagophthalmos was present. On palpation, the finger insinuation test was positive. The extraocular muscle movement in the right eye, there was mild dextro elevation at the primary gaze and restricted at all other cardinal gazes. The visual acuity in the right eye was much decreased than that of the left eye, which was finger count 5 feet, and with pinhole it is 6/60. Both the eye, the patient is pseudophakic with posterior capsular opacity, and in the fundus of the right eye, the media was hazy. The vertical cup disc ratio was 0.6, margin was blurred, and the NRR was pale, foveal reflex was dull, the vessels were normal, and no choroidal folds were present. From the history and the clinical examination of the patient, we can provisionally diagnose it as a case of unilateral proptosis due to the sinonasal mass. Then some of the routine investigations were done. The hematological investigation reveals that the hemoglobin count is a bit decreased, the C-reactive protein and the ESR is a bit raised. The thyroid profiles are within normal limit. Then the peripheral visual field shows there is gross depression in the right eye. In the left eye, there was nasal stip. Then radiological investigation was done. The MRI plane and contrast of the PNS and orbit and CCT orbit was done, which shows the large sinonasal space occupying lesion with multiple internal enhancing thick and thin septa seen epicentered in the maxillary sinus on the right side. And it extends into the right orbit, compressing the inferior rectus and abutting the medial rectus. Rest extraocular muscles are within normal limit. Then the right side, there is mild proptosis. Both the optic nerve and orbital apices are within normal limit. The differentials may be the retrobulbar hematoma, pseudotumor, carcinoma of the maxillary or ethmoidal sinus, meningioma of the sphenoid. For the management of the patient, we have done the tapping of the eyelids, then hydroxypropyl methyl cellulose ophthalmic gel 0.3% was used, antibiotic eye drop hypromelios, and nasal drop Gylomist was used. Then the case was referred to our ENT department, and they had performed the microdebrider and coblator assisted endoscopic endonasal debulking surgery under general anesthesia. And then histopathology was done. It shows the chondrosarcoma, likely grade 2. These are the histopathological slides, which shows extensive myxoid changes with bone permeation and the cartilaginous part is hypercellular. There is moderate to marked nuclear atypia. Then patient was followed up in the post-operative day 5. The visual acuity was a bit improved and all other symptoms were resolving. And the nasal endoscopy on the day 5 does not show any mass in the nasal cavity. Then for the further management of the patient, multidisciplinary tumor board was established. Then 2 cycles of chemotherapy was given with injection doxorubicin and injection cyclophosphamide. Then in the both eye capsulotomy was done and the patient was kept under regular follow-up. In the post-operative follow-up, after 2 months, we can see the best corrected visual acuity, which is 6/6 in both the eyes, and earlier symptoms resolved. And the post-operative MRI was done, and it does not show any residual or recurrent neoplasm. On to the discussion, that is one of the major causes of the unilateral proptosis is a malignancy that arises from the paraorbital region. In a study by Lenworth Johnson et al., 59% paranasal sinus tumor demonstrated orbital involvement.
Dr. Shipra, let's stop at this point of time. We will go for the discussion by the panelists. So we'll start with Dr. Rajesh.
Very interesting case, of course, and you presented very well. I think for me, our take-home message would be that obviously this is a malignant issue, but for a patient of the age which the patient has presented to you with the medical history of having a diabetes, I think it's important for us to remember that these people can also have, fungal infection of the sinuses. So, and also, most of the fungal infections are not so critical, but they can also have mucormycosis.
Yes, sir.
So that is something very vital. You do the right thing by involving the ENT team. It's basically ENT problem which is manifested in the orbit. So a multidisciplinary approach with the focus on the ENT surgeons is actually the way to go. Great, thank you.
Thank you, sir.
Dr. Shipra,
Yes,
what was the pupillary reaction in?
My pupillary reaction was reactive. There was no RAPD.
You said posterior segment was within normal limit, but your fundus is showing that there is optic atrophy-like picture. What was the actual picture? You can say better.
Ma'am, there was a pale disc. The neuroretinal rim is also pale. The margins were a bit blurred. So we thought.
How do you explain the 6/60 vision, the pale disc, and the pupil reaction normal? How do you explain it?
Ma'am, at first when the patient presented, it was a finger count at 5 feet. And
Why? That time what was the pale disc, no? That means optic atrophy has already started.
Okay, ma'am.
And after the surgery of such a big lesion, the vision has come back to 6/6.
Yes, ma'am.
This is miracle, I must say. This is miracle.
PCO was there. The visual field was normal actually. If you look at the visual field, it was normal.
The second point is the significant PCO. Definite point. Because in favor of that, in both eyes, this thing, but we overlooked that point because we thought that's not very important right at this juncture. Let us save the globe and the eye first and then we look for that.
Keeping in mind the age of the patient and with the severe chemosis, the first diagnosis will be always malignancy. Age of the patient. And regarding the duration, almost 1 year the patient was having this nasal congestion and this problem. If it would be a case of fungal, like mucormycosis, this will not take so much time, 1 year, it will not never take.
You studied,
Good case.
Thank you.
You studied the cranial nerve status pre-operative.
Yes,
What is the situation post-operative?
Sir, there was a cranial nerve 1, there was patient could not smell properly. Then in cranial nerve, the visual field that the patient could not see properly, we have shown from the periphery. And sir, the color vision that was perfect, that is she could read 21 plates. And
what sir is asking is post-surgery?
Sir, post-surgery that improved, sir.
All
Yes,
the
sir.
nerve status.
Even the olfactory function?
Yes, sir.
Saurabh, you want to?
Only last point I want to add. Last point I want to add. This is important. This is because if you see the patient, the nose appears to be almost normal. And ultimately you will end up into all these things. So a big credit to her for finding the case, did all that investigation. It is not easy to go for repeated MRI at our trust-based organization. And she has not mentioned, but on her behalf, I am mentioning, this is the first case of chondrosarcoma with sinonasal mass presented with this orbital disease, first in India. And good news is that in 6 months' time, she is going to present this at the academy meeting.
Tell me, what is the recurrence rate of such a patient?
Ma'am, recurrence is about 20 to 30%.
Huh?
20 to 30%.
And the survival rate?
Survival rate is about 90%.
Thank you, Shibra,
Thank
for
you,
the nice presentation.
What is the differential diagnosis, by the way?
Ma'am, it can be retrobulbar
Didi.
hematoma, carcinoma of the ethmoid or maxillary sinuses, or ma'am, it may be pseudotumors.
Pseudotumor.
I think we can discuss later on because we have to hand over me. Thank you.
A very good evening to you all. Today I will be talking a case of when nightmares become reality. First of all, I like to thank WSWB to giving me the chance to present it here. So I'll start with a quote of Oscar Wilde, that they have promised that dreams can become true, but forget to mention that the nightmares are dreams too. So 1 month back, I met with my nightmare. Unfortunately, I'm overcome with it. So this was a case which was referred for a glaucoma evaluation. She was a 39-year-old female. He is a known case of advanced retinitis pigmentosa. She complained of gradual dimness of vision in the left eye for last 6 months. She has a poor vision in the right eye for last 5 years. So when I examine her in anterior segment, patient has a large central vascularized scar in the right eye. So beyond that, nothing is visible. But his IOP was digitally high in the right eye. Come to the left eye has little bit congestion, shallow AC along with the NS2 cataract, and intraocular pressure was 32 millimeter of mercury. And when we do the gonioscopy, angle was occludable. So this was the picture. As you can see, it's an advanced case of retinitis pigmentosa with only a central macular part of retina looks normal. And if you look at the disc is a kind of dirty pale, and you cannot make out whether there is any kind of cupping is there or not. So I start with left eye YAG PI and start with the 3 drugs, Combigan, Bimatelis and Dorjox. No financial interest. And after 4 weeks, I examine the patient again. The IOP remains 30 millimeter of mercury. So after a maximal medical therapy in the left eye, only seeing eye, the patient has an intraocular pressure of 30 millimeter of mercury. So I have to do something, and that is obviously some surgical management. So I planned for left eye phacofoldable with trabeculectomy with MMC. So this was the video I am showing you. It's a very fast video anyway, to how I did the trabeculectomy. So I start with conjunctival dissection, and I prefer triangular flap. So I did a triangular flap over there, partial thickness triangular flap. Did a phacoemulsification. This is the rhexis done, and the phaco part of it. And then I put a 3-piece foldable lens. This was the patient's choice. After that, I enter behind the flap, do a punch with the Kelly's punch, and I did surgical iridotomy. After that, I put a single apical releasable suture. That's how I do trabeculectomy nowadays. So this is a releasable suture actually, and that suffices. After that, conjunctival closure was done. So this part is okay. I just wanted to show you that the surgery was uneventful. It was a routine phacoemulsification with trabeculectomy. So this was done, and after any kind of glaucoma surgery, I called the patient in the morning. So in the next morning, first post of day, patient come at the 9 a.m. and this was the situation. The situation is that the patient has a totally flat AC. You can see the oil just coming out of the bag, and there's an optic capture and trying to touch the cornea. So there's a very shallow AC, And you can see the bleb is also flat, the PI is open, and the intraocular pressure is 58, doubled. So the situation is, in the first postoperative day after trabeculectomy, I have a very high intraocular pressure with a very shallow AC and flat bleb. So in this situation, the differential diagnosis is obvious. There will be the 4 differential diagnoses. First is pupillary block, and that can be obviously ruled out because PI is patent here. Other will be the choroidal effusion, suprachoroidal hemorrhage, and last is malignant glaucoma. And this last 3 entity only can be differentiated by the UBM, as Soubhikda said, that UBM is necessary. So UBM is necessary to differentiate the condition. So I did the UBM, and as you can see, there is a forward movement of the lens iris diaphragm. And if you see the ciliary bodies there, ciliary bodies are anteriorly rotated. And there is no suprachoroidal hemorrhage or choroidal effusion, so diagnosis was confirmed, it is a malignant glaucoma. So at that time I panicked because malignant glaucoma is very difficult to treat, and if you do not treat properly, the patient is gonna blind because patient is a one-eyed patient. So at this point I started the initial medical management. I started with mannitol 200 milligram IV, I give cycloplegic and topical aqueous suppressant. And I check the intraocular pressure 1 hourly. But after 4 hours, the IOP remains 60 millimeter of mercury. Now what to do? At this point, I have to do some kind of surgical intervention. So 2 points are there. I have to disrupt the anterior vitreous phase. That can be done with the laser, that YAG laser or argon laser, or better if you go for a pars plana vitrectomy. So I planned for pars plana vitrectomy. The problem is it was Thursday, and in Thursday, sorrowfully, no retinal surgeon was there. So at that time, I have to do it myself because I routinely done pars plana vitrectomy in if there is a PCR in normal cases. So pars plana vitrectomy is not new to me, but this kind of cases, how it will respond, I do not know. So I start the case like this. So this was the people, when pupil is dilated, I taken as a topical case, I introduced the lidocaine first. Then I introduced some high molecular weight viscoelastic, but it was impossible to form the AC. So whatever I inject, it's coming out, and ultimately iris tend to come out. So what I did, I go into the head end and take a trocar and 3.5 millimeter away from the limbus, I introduce the trocar. Now I introduce the vitreous cutter in a cutting mode and go behind the lens and posterior capsule and try to eat away or suction away as much as vitreous as possible. So after 1 or 2 minutes when I done, I came out, and you can see eyeball is little bit of softer side now. So again I go back to the temporal side and try to form the AC, and at that time AC was deep. So AC was deep, and at that time I noticed that IOL has subluxated a little bit, so I just rotate the lens and put it into the bag again. Remove the trocar. And remove the viscoelastics from the anterior chamber and form the AC. And pray that in the next day it will be okay. So next day, fortunately, it was okay. The patient's anterior chamber was well formed. Intraocular pressure was 60 millimeter of mercury, and vision was around 6/60. Sorry, I do not have a post-op picture of first day. So patient is doing well for the last 28 days, and I'm keeping the patient with the steroid, cycloplegic, and only one drug he's taking is a Combigan. So this was my nightmare, and I came over it. So thank you.
Very well, man. Saurabh.
I have I have few questions. তুমি আমার থেকে ছোট তো আচ্ছা একটা The patient was sent to you for glaucoma evaluation, no?
Actually, and it was referred from the cornea department because of the corneal some problem was there in the right eye. You know that patient has a
You
star.
said that there was AC or shallow, okay?
AC was shallow in the left eye.
What was your gonioscopy finding?
Occludable, I already written.
Gonioscopy finding?
Yes, occludable.
And this visual field?
Field I have not done at this point because it was very difficult to determine the extent of the glaucomatous damage in a patient of RP. I already told the patient has an advanced RP.
When you diagnosed it as a case of malignant glaucoma, you did an ultrasonography USG B scan?
B scan was not done, UBM I have done. I have shown in the UBM. B scan will be, UBM will be much
That
more
B
valuable
scan-
at this time rather than a B scan.
B scan will show you the pocket of the aqueous.
Not necessarily at this point, but in few cases you can see that the pocket of the fluid in the posterior vitreous, you may see it, but definitive diagnosis will be in the angle. So at this point of time, as I have an opportunity of doing a UBM at there, so I did a UBM and UBM is a confirmatory.
What we know is that retinitis pigmentosa is causes open angle glaucoma. But what is the percentage of these angle closer glaucoma?
No, actually retinitis pigmentosa, I have searched for literature, but in anywhere there is no correlation between the retinitis pigmentosa per se with that of the malignant glaucoma. But there is a correlation.
We know so far that it causes open angle glaucoma, secondary.
But in
But
this
there are
patient, in this
associations. There is
patient,
angle
the
closer
eye
glaucoma
was,
in RP also. RP also, we can see angle closer glaucoma.
I want to know
percentage.
just.
Just let me answer this. RP does not have to relate it with this disease entity. The more important is that patient has an angle closer glaucoma that is causing these things, because it's very well known that angle closer glaucoma after surgery
Causes
may
malignant
end up
glaucoma.
malignant glaucoma.
Yes.
So retinitis pigmentosa is an incidental finding here, not necessarily this.
That may
I
not
know
be.
that.
That may not be. That may not be. It may be.
I did not find any literature
It
actually.
may be association also. Yes. It may be association.
What was the axial length of the in biometry, and what was the
Biometry I have, biometry was around 23. 23 was the, I can
23.
remember. Axial length was normal side, so it was not much of a difference.
Okay.
So it was on the,
What is there in the literature? What is there in the literature that's in a Chinese population? I have seen also. Amitoko Patabu. Whenever you are seeing any occludable angle, particularly in a this RP setting, primary retinal dystrophy, then definitely there is 30% more chance of developing angle closer glaucoma here. And what they have advised, possibly did you did the surgery under mannitol?
Surgery under?
Mannitol?
ম্যানিটল দিয়েছে ম্যানিটল দিয়েছে
হ্যাঁ,
সব
mannitol,
দিয়েছে
of course.
Mannitol
তুমি
দিয়েছে।
চা খেতে গেছিলে তুমি শোনোনি অর্ধেক কেস
না, 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 আমি শুনেছি।
সো মেইন ইম্পর্টেন্ট পয়েন্ট
তো না, তুমি আসল দুটো পয়েন্টে ডিসকাশন করোনি।
কিসের
Two important points. Number one, you have started with the beautiful quotation of Oscar Wilde. তুমি অডিয়েন্সকে বলো তুমি কার কার স্বপ্ন দেখেছো, কার মুখ স্বপ্নে এসেছে।
Shomendra, I have a question.
Number one. Number two, I can see Bhaskar.
Shobhita, this is a serious discussion is going on. So we have 5 more cases we need to finish by before this. Please,
One thing is
we'll come to you later.
First of all,
Maitreyi.
when the patient presented with you with a high intraocular pressure, you started with multiple medications initially, but with no response. But after that, you didn't bother to reduce further with the systemic acetazolamide and bring it normal and then proceed for the
No,
surgery.
actually what happens, the problem with this patient I'm telling you, patient is a one-eyed, vision is also compromised, and I do not know properly
It will
what
take
is the
maximum
damage.
7 to 10 days of time to reduce the pressure to the normalcy and keep it there for some time and then take
And
the
would you
patient to...
think that in a patient who is taking the maximal medical therapy, which is 32 millimeter of mercury, adding some kind of, again, oral acetazolamide will reduce significantly?
Yes.
Do you think?
Yes. Definitely. Definitely.
That will be a short term. That will be in a short term.
For the short term, you have to take the patient
Then what
to
to do
theatre.
again to do the surgery, na? So that
Yes,
is
but
what.
reducing the pressure is very important. Yes. Another thing is that during angle closer glaucoma, it is mandatory to make the antechamber as deep as possible and tighten the suture, not only a single suture on the apex. On the base, there should be another one releasable and one permanent for the angle closer glaucoma to have the anterior chamber deep post-operatively.
No, that's okay, but in my
It's not
cases,
okay.
it's not a single case I have done. I have done many
But
cases
you're
with the angle
fortunate
closer.
enough,
My
but
experience
post-operative
shows
shallow
that's not
AC
any
is very
problem.
important.
This is only one case happened. So because of the one case,
You are very lucky that you didn't get it, but there is chances of post-operative complications in angle
That
closure.
is possible,
I agree
but
completely.
in my series,
So
there is
now
no
the most
complications, so I am
important-
confident to do them.
Yeah, Nilayda.
Fibrosis, chance of fibrosis is much more in this particular case, na? Because in retinitis pigmentosa, chances of fibrosis is much more.
So a wonderfully managed case. Congratulations. I just had one point to mention, that it is very important for the anterior segment surgeons also to know the skill of pars plana aspiration of the vitreous, which you did for malignant glaucoma cases. And even I have done this. My only 2 cents here is you can palpate the globe with the left hand with the buds or tip, so that to say the globe is not getting too soft during the aspiration. So the other retina surgeons can correct
No,
me.
the question was not to reduce the pressure here.
No,
Cutting and
Showman.
aspiration of
I'll
vitreous.
just add one more point. This is what he did, absolutely correct. Probably the main treatment for vitrectomy is the main treatment for malignant glaucoma. So at any point of time, we need to do. So he has taken it up at that point, is agreed with that. But what you are telling also, lowering and after that reduces the complications. What I would add at this point of time, what you did is probably from 60, that sudden hypotony could have caused the choroidal detachment or the suprachoroidal hemorrhage. So that is probably the another point of concern was here, so that you can infusion put it and maintain it properly. Otherwise, I think this is very well managed. Next of the things, I mean, hats off to you that you have the courage to take it up and then did it on the same day.
Okay, thank you.
I mean, thank you. Next time I promise that we will put the retina cases first, and then she was telling that this is okay. We'll move on to our next session. Hand over to our next moderator, Dr.
Thank
Sangeeta.
you, sir. So we will quickly go to the next session. We are already late for that. I would like to request Dr. K.P. Ghosh and Dr. P.N. Bisha, sir, to please chair the session. And may I please request the panelists to come forward, Dr. Siddhartha Ghosh, Dr. Arnab Das, Dr. S.S. Paul, and Dr. Obhijit Chattopadhyay. I think he is not here. So we will start with our first topic. Dr. Debmalo Das, what's behind the mask?
Good evening, everybody. After fighting with 1/4 of the eye, let us see what the rest 3/4 does. So my topic is, who is behind the mask? So this was a 27-year-old male complaining of diminution of vision in the right eye for 5 months. It was sudden but painless in onset. It was diagnosed as a case of central serous chorioretinopathy. And many places, he went around many places, and somewhere it was diagnosed as a case of posterior uveitis. He became a steroid responder, and many people felt that the CSR was because of the steroid use. And patient was on anti-glaucoma medication. Vision at that time in the right eye was 660 and 24, other eye was normal. So this was the picture. As you can see, there is a cuff of fluid here and a lot of hard exudates. You can see tinge of bloods here and a lot of hard exudates around. To get a better picture, you see this. So you get to see a lot of hemorrhages, lot of hard exudates, especially at this point, and a lot of capillary non-perfusion areas where there are no blood vessels at all. So this was the OCT, and perhaps this actually what the people mistook it to be a case of CSCR, and also exudates led to the diagnosis of posterior uveitis, but there were no cells and flare. Though, as I told you, the case that we'll discuss about do sometimes have inflammatory response. Now, when you did an angiography, a classical case of Coats disease came out. How? So this was an intense lesion. So this intense lesion was leaking, and you can see the classical, why is this flickering? I have no idea. Anyway, so you get to see a classical fawn pattern and large capillary non-perfusion areas. You can see the telangiectatic vessels, and as I tell, this is a fawn pattern. This is classical of Coats disease. But what was that intense lesion? So that was adult onset Coats disease with a vasoproliferative tumor. So what we did laser followed by anti-VEGF injection. Now this laser was done on parts. I didn't do it at one step. I did laser on the lesion as well as surrounding CNP areas and the telangiectatic vessels on a particular day, and after 2 weeks I again called up the patient, saw the patient, did further laser, and then anti-VEGF injection was advised. So with anti-VEGF injection, this is how the patient responded. The fluid had completely gone, hard exudates, because you have given anti-VEGF, slowly coming into the fovea. But since I had done laser, the source of hard exudates were gone. So this is how it looked at presentation. I have shown you this picture in the first few slides. This is after the first setting of laser. You can see the hard exudates are gradually reducing in number. Also, this lesion is bleeding a little bit, so I added a little bit of a more laser and watched. And this is how it is now. So this is about 6 months ago. Now this hard exudate is also completely gone. You cannot even find out the thing that was there and that was causing a nightmare to the patient. And this is how the OCT was. Gradually the edema reduced and the patient had a vision of 6, 9, and 6. As I told you, adult onset Coats disease itself is a rare disease, and with a vasoproliferative tumor, it itself is rarer still, and laser cryotherapy and anti-VEGF with steroid is the treatment of choice. Thank you.
Thank you, Dr. Demallo. So what are the parameters that you used for the tumor per se, not the CNP areas, for the tumor?
So you cannot give short courses of laser.
Yes.
You have to have a long duration of laser, but make sure when you do laser, follow it up, because sometimes in large tumors, traction do arises. And if you give anti-VEGF in a vasoproliferative tumor just like that, it can cause traction, it can cause contractional retinal detachment. So you have to gradually see how the patient is responding, give injection accordingly.
So to some extent, it's like the way we treat retinal angiomas. First, we do slow
Kalpita
lasers.
is there. She can further shed some light. Ranibizumab.
So,
Razumab.
Rajumab. Very
so
good.
as sir clearly mentioned, in angioma also, in VPT also, the differential between angioma and VPT in these cases where there was no feeder vessel. So this was not an angioma, this was a VPT, and it was very well documented with that angiography. This was a VPT secondary to Coats disease. So treating that directly on the tumor should be a low duration, high duration, low power burns. So that's what you did is, that's what usually we should do.
So,
it should be a continuous burn, and you aim is to create a little bit vasculitis, so that will close. I feel it is in this case, cryo is also another good option.
Sir, if laser can be, because laser causes less inflammation, so if it is laserable, then we can laser.
So my problem was two things. One is that it can be also solved by IVTA injection, because Ozurdex and IVTA helps equally well when it comes to hard exudate. Problem is he was diagnosed, I don't know whether at that time he had an inflammatory episode or not. He was diagnosed as a case of posterior uveitis. So I didn't know whether inflammation might subside. That was another reason why I didn't give cryo.
So we'll take one question before she starts.
Because this is 28-year-old male, they have better prognosis, they will have hard exudates, they respond pretty well. Children generally they will come with full Coats disease. You will get yellow reflex.
Coats disease can have a continuum, and he has a VPRT which suggests that it could be a chronic.
Yeah, so he has been there he has vision loss for 5 months. It might be there for 2 to 3 years, even more than that.
Which presents in children will not have this localized presentation till 20 years of age. So either it will resolve or it will have an extensive Coats-like changes, all subfoveal fibrosis, because the Coats disease response in children have a very high exudative response. They usually end up with subfoveal fibrosis and extensive exudation.
So we will go to our next. If we don't have any question, then we'll go to our next topic. Thank you, Dr. Demallo. So our next speaker is Dr. Amrita Pradhan along with Dr. Kalpita Dash, double trouble.
Very good evening, everyone. Today I am going to present an interesting case. A 79-year-old female presented to us with floaters in her left eye since 4 months. She is a known case of primary angle closure glaucoma on treatment. Her past history was significant. She presented with 4 years back. She presented with right eye with severe proptosis, chemosis, and restriction of eye movement, for which she was treated with oral steroids and she got relieved. Again, after 2 months, she presented with very severe chemosis, proptosis, restriction of eye movements, choroidal folds in right eye, and her vision was reduced from 6/24 to 5/60 in her right eye. So a contrast enhanced MRI done, it's shown in the picture. Axial scan showing an homogeneously enhancing well delineated intraconal mass with molding the globe and optic nerve. As seen in the coronal section, we can see there is molding around extraocular muscles with no infiltration. An incisional biopsy done, which was non-Hodgkin's lymphoma, diffuse large B-cell type of lymphoma, which was confirmed by immunohistochemistry, for which she got treatment with 6 cycles of R-CHOP and external beam radiotherapy. Again, she presented to us after 4 years on March 23, having in right eye having no PL, and in left eye she presented to us with floaters in left eye. As she was one-eyed, she was very hesitant to do any investigation in this visit. Again, she presented to us after 6 months in September 2023 with gradual increase in floaters. As seen in the slit lamp, we can see there is some vitreous cells in vitreous. Then in fundus picture, we can see right eye media is clear, and glaucomatous optic atrophy we can see. In left eye, we can see there is media is hazy with complete PVD. Macula and blood vessels is normal, and optic cupping is there. Then in OCT, we can see some vitreous cells are there. Otherwise, foveal contour is normal, and all other retinal layers are normal. We have done ultrasound B scan. We can see there is IOL reverberation echoes with some VT echoes and complete PVD. Then we have done CSF analysis and contrast enhanced MRI brain and left orbit on September 2023, which was found to be normal. Then we have decided to do vitreous biopsy in left eye in October 2023, which was found to be primary vitreoretinal lymphoma, and which was confirmed on immunohistochemistry as non-Hodgkin's type of lymphoma, which was DLBCL, diffuse large B-cell lymphoma. Then she was treated with intravitreal rituximab 0.1 milligram under topical anesthesia, 3 doses given subsequently. In November 2023, she presented with us with vertigo, so we have done MRI brain and orbit, which show large cerebellar deposits. For this, palliative radiation of whole brain given on December 2023. And we have done also MRI brain on 12 January, which showed partial response. Till now, she has received 4 cycles of TMZ, that is temozolomide. Last, she has received on 15th April. So, I will, in general, with modern treatment of patients with non-Hodgkin's lymphoma, the overall survival rate at 5 years is 60%. More than 50% of patients with aggressive non-Hodgkin's lymphoma can be cured. Most relapses occur in the first 2 years after therapy. The risk of late relapse is higher in patients who manifest both indolent and aggressive histologies. Simultaneous occurrence of intraocular and orbital lymphoma occurs, but is rare. Intraocular lymphoma usually appear in conjunction with primary central nervous system lymphoma. The most common manifestation is tumor infiltration of the vitreous. The prognosis of ocular lymphoma depends on tumor's histologic type, stage, and treatment employed. Similar case report, a few case reports found. Thank you.
Thank you. I would like to request Dr. Kalpita Das to please to have the discussion.
Hello. Yeah, so the unusual thing about these cases where the patient had a orbital lymphoma 4 years back. So orbital lymphoma has association with systemic lymphomas, but association of orbital lymphoma with primary intraocular lymphoma or primary CNS lymphoma has not been described. So even though we know that the histologic cell type are the same, both are diffuse large B-cell lymphomas, but we know that the pathogenesis are different for both the cases. So this was particularly one case because we saw those floaters and she was very apprehensive to undergo any investigations or any intervention in that eye. But because she was extremely photophobic, and you can go back to that photograph, she has a large floaters with lot of cells. So that time we had finally planned for that vitreous biopsy, which showed us a primary intraocular lymphoma. And unfortunately, that time the MRI was normal, but subsequently in 3 months' time, she presents with vertigo, ataxia, and all those things. We found out there's a large cerebral deposits also. So now the entire spectrum is complete, that the patient had a primary intraocular lymphoma followed by a primary CNS lymphoma, and the prognosis remains definitely very poor in these cases.
Just one word of caution that in these patients, you should not get swayed away if you see vitreous cells and waste your time on putting the patient
Yes.
on steroids and seeing the response and then taking. You were lucky that you knew the diagnosis was already a lymphoma.
So
but even if the
most of the cases, that's why this is masquerade, because most of the cases actually come to us with which has been treated with steroid, because they respond to steroids. So they will respond to steroids again after when you stop the steroid, they comes back with similar symptoms.
Just a very quick comment. Can I just go back to your OCT picture? So if you see that kind of coarse deposits over the retina, that is very, very unlike for a uveitis cases. So that is probably one of the clinching point here that you should, and the kind of, ultrasonography, the kind of, involvement of that, posterior vitreous. So these are, and if you see slit lamp, the vitreous cells definitely would have been much more larger and coarse. So, and history of lymphoma. So all 3-4 points, if you put it together, probably you will go towards the diagnosis of
And as sir
primary
told,
intraocular
in,
lymphoma.
Presence of vitreous cells, which is coming for the first time in an old age person, we should always suspect lymphoma.
So take home message is we should have a class on masquerade syndrome, sir.
Rupak, that's a very valid point which you mentioned. The OCT findings should kind of hint. And there is no retinal edema at all. With that much of posterior vitreous inflammation, if it was inflammation, there would be retinal edema. So CME would have been there. It's not there.
Yes.
So again, that is something that should hit.
Yes, any cells and extremes of ages, uveitis should be taken well care of. We should not start steroid right away. And this discussion can go on and on, but we have to go to the next topic. Dr. Bhaskar Ghosh, our next speaker, along with Dr. Sudipto Das, creamy eye.
Good evening, my seniors and colleagues. I would like to thank OSW for giving me this opportunity to present my case. So first of all, I would like to ask the audience a simple question. Can you please have a look at this strange looking fundus?
So can you gauge the vision in this patient? 6'6" and 6'9", PL positive, bilateral PL, NPL. So this patient, Bhaskar, you can go on.
Okay, let's continue with my case.
So patient doesn't have any visual symptoms.
Okay.
So it's an incidental finding.
So this is a case of a 37-year-old known hypertensive male patient who presented at our OPD for his routine examination. His visual acuity was absolutely normal in both eyes, that's 6.6 and 6. His slit lamp examination was within normal limit in the anterior segment. Both eye was phakic. His IOP was also within normal limit. His dilated fundus examinations showed a strange creamy white colored blood vessels throughout the fundus. So this is the color fundus photograph that I have already shown you. This milky white appearance of the retinal arteries and veins was present. We did an OCT which showed some hyperreflective and engorged retinal vessels and white dots in the inner nuclear and ganglion cell layers. This is the OCT presentation. On further examinations, his hematological investigations came out all normal, except his serum cholesterol level was slightly more than the usual normal range, but his triglyceride level was much more.
So Bhaskar, just stop. So at this point of time with 6.6 vision, no visual complaint, any differential diagnosis in your mind? Familial? So you can go ahead with this.
Okay, so we just referred the patient to his physician to control his triglyceride level. His age was 37 years old and he came for his routine examination. So we sent the patient for a systemic evaluation and to control his triglyceride level. After 3 months, he came back to us again with the completely normal fundus photograph, with his triglyceride level also within normal range. So with all the ocular features and the imaging, we came to the conclusion that this was a case of lipemia retinalis.
Creatinine was okay. Only triglyceride I think was 2000. 2000. So that only triglyceride was high. If you see the fundus photograph, can you just go to the fundus photograph? So you can see the a normal calibered vessels. You don't have much hypertensive changes also. Apart from the color, everything else apparently looks normal. And if you go to the OCT, you see the OCT there, you can see a localized area of inner retinal hyperreflectivity which goes against ischemia. Because if you have ischemia, you will have an area of ischemia, it cannot be so localized. And there are some white dots which are the chylomicrons, they tell the chylomicrons which you see in the blood vessel layer. So these patients are apparently absolutely normal, even the fluorescein angiography also is normal. So they will have all reports normal apart from the discoloration. So that is because of the chylomicron, blood vessels are clogged with chylomicron, but it's not occluding the vessels. So because of that you get this color. Yeah, the same thing, because you have very high, and there are two methods to differentiate that. One can be occlusive also because of very high cholesterol and LDL, where you have patient's visual symptoms and you have angiographic findings. Here you will not have any specific findings, and the OCT also is a little different in those patients who have occlusive.
So what prompted you to get what prompted you to get a lipid profile done in this patient?
So the look
of the
look,
and
it looks like lipid.
And this in the lipid profile is in these conditions, is the triglyceride level which is most prominently high, or the other parameters are also high?
It's the triglyceride which is most prominently high, and it's in thousands. Most of the time it's, that's very important point. LDL, HDL, maybe within normal, or LDL and HLDL, but triglyceride is very high. Now if you, total cholesterol can be high, but it's the triglyceride which is very high.
One thing, why the fats deposited on a particular area of the OCT? Why it is not?
No, it's the vessel you are seeing, sir. You are seeing the cross section of the vessel. You are seeing the cross section of the vessel and that area. So you are not seeing the whole area. You are seeing the cross section of the vessel at that area, and that's because the reflectivity of the chylomicrons, you are getting this OCT. Now suppose you are getting an occlusive retinal problem, usually we have a area of retinal hyperreflectivity, not a specific zone. Sir, you are getting a reflectivity because of that zone. So it can be, this is the, you can see the, same eye, this is the same eye? Same eye? I think taken from same eye. It's a different section there.
It's just like a fatty liver. It's a fatty retina.
Patient, I think patient had some family history.
Yes. Not
patient had some family history. No,
don't have the family history of
you have the parameters, blood parameters.
Usually.
I want to ask two questions.
Other parameters were within normal limit.
One question.
What? Some parameters were there? No. Apart from this was the total cholesterol was 295.
We came for the routine test, and we did a dilated fundus examination, and just got this picture. No.
Patient
was maintaining the
come,
vision.
I think for refraction.
6 and 6.
These patients, if they remain untreated, what is the consequence?
But these patients can actually lead, go for thrombosis if it is chronic. Because these lipids, these chylomicrons, now instead of having a non-occlusive condition, it can go to occlusive disease. So then that can actually have problems.
Triglyceride level of 1400. And later on, she had to go for renal vessel there was stenosis and uncontrolled hypertension. So they had put in a stent, multiple stents in the renal vessels. What I'm saying is that that patient has to be followed up.
Yes.
Because they might develop
So
later on.
Absolutely.
That goes to my question, like when it's been treated, so what was the cholesterol level post-treatment? Because as far as I know, it's not very easy to treat them and bring the cholesterol level to absolutely normal. That is
Below
one.
500.
Below 500 is
500,
normal for that. That's what I wanted to know. And another thing is that it is only they were treated with anti-cholesterol, like triglyceride drugs, because a lot of them have insulin resistance. So sometimes they are put
So this
put
patient
into
was
other
non-diabetic.
like
There was non-diabetic.
Non-diabetic.
It was just known hypertension.
Yes, but it's true that if you treat with insulin also, you treat triglyceridemia. So, and because it depends upon the type of hypertriglyceridemia. We had these 5
I have a
types of
similar patient,
triglyceridemia.
young, who had a cardiac stenting done, who is uncontrolled hypertensive and diabetic and have high insulin resistance and this thing. Retinal findings were not there, but familial hypertriglyceridemia who came to as a vein occlusion. So they need to be followed up very closely and for other systemic parameters, for like cardiac issues also.
So I think last one discussion point, that's last one. Anything else? Anything else you want to add? One single point which you have missed? Ashwar? So these are differential diagnoses. Anything else you want to add? Anything we have
No,
missed?
there's few differential diagnoses.
No. Any discussion? Anything we have missed?
No. When the triglyceride levels becomes normal, usually these findings
So
goes
that
away
fundus
within a
picture-
week only.
The fundus picture what we have taken after that time triglyceride was around 500.
500.
So for him I think it's that.
We will go to the next topic.
Next.
Dr. Prashanjit Mondal saving.
Only one point what he was showing, no, that blood vessels which were normally we don't see like that kind of large blood vessels. And along with normal, if it is normal blood, it will not show that much of reflectivity. So what you are seeing is probably that goal 3 pictures, no, that is a cross section of the blood vessels, which is not actually blood. So that's what is probably the clinching, diagnosis from there, other than the fundus picture.
Saving the eye after dengue. Dr. Prashanjit
Good evening, everyone. I'll be just presenting a case within a video. Let me just present the case, and after that, we can take few questions. Okay. So let's begin with the case. Just 5 minutes case only.
Give.
A 45 years old female patient, by profession a teacher, presented to us with a history of defective vision in the right eye since last 7 days. She had a history of infection with dengue 1 month back. At present, her hemoglobin was 11.5%, platelet count was 2 lakhs, and bleeding time, clotting time and prothrombin time was within normal limits. On examination, her best corrected visual acuity was finger counting at half meters in the right eye, and the left eye was 6/6. Fundus examination revealed pre-retinal hemorrhage in the right eye just over the macula. We planned for a pars plana vitrectomy with internal limiting membrane peeling in the right eye. We started with the pars plana vitrectomy. Intravitreal triamcinolone acetonide injected and PVD induced. Brilliant blue G dye injected and ILM stain. peeled off slowly. Now we slowly remove the clotted blood with passive and active suction. To my utter surprise, I noticed branch retinal vein occlusion, which is a rare phenomenon associated with dengue hemorrhagic diathesis. Endolaser was done in the affected area. Fluid air exchange done and the ports closed. Retinal hemorrhage is a potentially serious complication of dengue fever. The onset of the symptoms appears to coincide with the resolution of the fever. Patients with dengue fever who reports visual symptoms should be examined promptly, and with proper management, vision can be restored early. Thank you.
Thank you, Dr. Prashant. Very nice case. Yes, dengue can appear with a lot of findings in the retina. There can be arteriolitis, there can be CMEs, there can be hemorrhages like this. Even vitreous hemorrhage has also been reported. A lot of hemorrhages have been reported. Was any pre-op OCT done for this patient?
No, I could not do a pre-op OCT.
Because what happens is, had there been a pre-op OCT, this ILM, sub-ILM bleed can be diagnosed early, because Dr. Maiti is not here, but he had once shown a case where he thought it to be a pre-macular hemorrhage, and he put the jet of the back flush and there was a macular hole formation. So we can be more careful had there been a pre-op OCT. Post-op vision.
Post-op vision was 6/9. Yes. Yeah.
Yes, 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 yes.
One interesting point is like the presentation. Till what time can a patient of dengue present with eye complications?
So the patients
about, it was rightly mentioned, like you got the patient at about 3 weeks' time.
At about 3 weeks' time.
Yeah.
When the post-febrile, the visual symptoms appear.
It is reported, it could be as early as 5 days
Yes.
to about 3 weeks.
I have a case reported in British Journal of Case Reports where the patient presented within 5 days, and at that time the platelet count was 60,000 or 50,000 something. So I had to wait for the platelet count to be normal and started the patient on steroids. And there also I was in doubt whether to start him on her on steroids or not, because of the systemic condition.
As the patient was a teacher, she wanted to go back to the classes early. So I waited just for the platelet count and these parameters to be normal.
I mean,
yes,
what is the cause of hemorrhage in spite of the fact that the platelet count was 2 lakhs?
No, sir, I was waiting. Until the hemodynamically the patient becomes stable, all these parameters become normal. This, actually, the patient got it 3 weeks back. After that, post 3 weeks febrile, then the bleeding, this platelet count and all, they became slowly improved.
Oh,
Yeah.
You mean the hemorrhage occurred during the fever,
during that post-febrile, it appeared. So we have to wait until and unless it becomes...
Why did you not go for an OCT? The medium was
OCT could have been done, but I saw it clinically, it was very much obvious that it is a pre-retinal hemorrhage. Yes, sir, OCT could have been done. I could have done. Subhyaloid. No, sir, it was yeah, subhyalem hemorrhage is this is a pre-retinal one.
And one question, sir, for
So it goes away on its own.
Yeah. I also agree to it.
Like dense ILM bleed. Okay, I waited almost around 5 weeks. Within 5 weeks, the patient got back almost 6
Yes, sir.
vision.
We could have also gone through a conservative approach of giving a C3F8 gas and prone position.
But
But
the
patient wanted,
subilum bleed goes away. So subilum bleeds, they are a little bit resistant for result.
There is a drastically, suddenly the vision from counting finger 2 meter to 6'9". Okay, then it becomes 6'6". Okay, within another 2 weeks. So in that case, there is no hurry to go for the surgery.
So one question to you, sir, if these kind of patient presented with inflammatory, like you said, foveolitis or arteriolitis, which is very close to the macula, can we start steroids in these patients?
Most of these dengue retinal complications and other eye complications are treated with corticosteroids only. They respond very well.
One question.
What variety it was? Did you go for that? It's a dengue 1, 2 or 3?
No, sir.
You didn't?
I didn't.
Okay.
Very
And the second is that whatever literature I could find, retinal complications are really, retinal hemorrhages are really rare.
They're
in
not very
dengue.
uncommon.
Yeah.
The second point is that whatever is reported in the literature, these are also, even if there is a sub-ILM heme, along with vitreous hemorrhage, then people have operated that. And I agree with Dr. S.S. Paul that even if it is 5 to 6 weeks, possibly your approach was a bit aggressive. You could have waited for some time more.
No, yes, sir, you are absolutely right. But the patient, as being a teacher, she wanted to join the classes and all these things immediately. And I waited till the bleeding diathesis becomes controlled and all this platelet count and prothrombin time, they became...
Doing justice for both the patient and the hospital.
2 questions done, sir.
Okay.
So I have given
11
it's
point
around
something, 11
14, I think. I have written there. It's 14. It became normal, absolutely.
We will go to the next. We have already crossed our time. We will go to the next topic. And Dr. Jonaki Ghosh Roy and Dr. Shubhankar Shripal. The topic is why the disc is swollen.
Good evening, everyone. My case is a 19 years old female non-obese who presented to us on 26th of March with complaints of seeing sparkles of light in front of both eyes. She was as well experiencing tinnitus and headache. So we were of the thought of routine flashes kind of presentation. On examination, the vision was normal, 6.6 and 6. Intraocular pressure was also normal. Pupils, there was no RAPD, and slit lamp finding was normal. Now, when we proceeded for the fundus examination, we saw a bilateral disc edema. Soon, retrospective analysis, again, the patient came up with the fact that she was diagnosed to have rosacea, for which she was started on oral minocycline, which was started from somewhere mid-January. And after that, she was at that time she was on minocycline twice daily by the dermatologist, and followed by once daily course. When she suffered from persistent headache and pain at the back of the neck, which was associated with vomiting and tinnitus, and she experienced that showers of light, which was increasing in frequency and intensity. Now, she had received a dose of intravenous methylprednisolone, which was advised elsewhere, and was put on Diamox also. Now, thinking to be in the line of, the minocycline to be the causative agent, we further investigation showed that color vision contrast was normal, the neuroimaging was normal, and contrast enhanced MRI showed a thickening of the optic nerve head with the optic nerve sheath. The fields were also normal. USG was also done, it was normal. it showed disc elevation, but otherwise it was normal. So a differential diagnosis was made of papilledema and optic neuritis. So minocycline was stopped and Diamox was asked to be continued. And then the patient had come for a follow-up on 5th of April when we see that the edema has subsided, although some amount of residual edema was still there in the left eye. Subsequently, the patient was followed up on 8th of April, which showed pretty improvement. And last visit was on 18th March when the disc was almost normal. Vision was also normal and the patient was subjectively better with respect to the symptoms. So basically this timely diagnosis of this minocycline induced, not only drug induced increased intracranial hypertension is important to, because there are case reports which says that there can be severe loss of, irreversible loss of vision with with this kind of drug. So timely, timely intervention and timely diagnosis and management would have saved the, severe loss of vision. Yes, vision, exactly, sir. The vision was good, the color vision was also okay. And so that was the reason that pointed out, we again went back to the history, that what exactly, are you on any medicines or, and we have checked the blood pressure also, that was also normal. And so that we went retrospective, and then the patient came out with the fact that she was diagnosed to have rosacea, for which she was placed on minocycline.
Diagnosis?
She was started on medicine from 15th of January, and her symptoms, yes, and her symptoms started from 28th of February, 6 weeks like that. Previously, initially she was put on 100 mg twice daily, but after that it was decreased to 100 mg once daily. When her and then only her symptoms started.
I have a question. You rightly pointed out that there may be a possibility of papillitis and papilledema, okay? So bilateral simultaneous papillitis is very rare.
Yes.
But still there is a differential diagnosis.
Yes.
If that happened, how do you differentiate it? All these things indicate there is a possibility of a papilledema. But if it is a case of papillitis, how do you differentiate it?
Probably the vision would have been...
No, you have to do VEP at least. VEP you have not done. That's why I am asking this question.
No, VEP was not.
That should be done.
But vision
yes,
and
that was advised by the neurologist also, but the patient did not go for any intervention. Yes, that was very much advised by the neurologist. The
problem
is now here the 2 points were here. Whether the ICT was raised or not, that has to be differentiate between papillitis and papilledema. So that is probably, that's what she told, patient did not agree for that. So otherwise from there itself it would have been differentiated between those two. Second point is that whether it is a minocycline induced II intracranial hypertension or it is an IIH. So these two to be differentiated. But because after stopping retrospectively after stopping minocycline, so probably that is an indication.
Yes.
And there are reports that minocycline has been known to cause like this kind of. So the purpose of the case is that even kind of a drug which is before diagnosing of IIH, there are few drug history probably can give us in a other insight for like this kind of cases.
Now the problem with minocycline is that it has a greater lipid solubility. So for all these doxycycline, minocycline, azacycline, all the cycline groups, it has got a greatest penetrability in the CNS circuit. At this juncture, it actually competes with the glycosaminoglycans and put almost like a demyelination type of condition. But the take is not that in case of acne vulgaris or acne rosacea you should not be using, because the problem happens with only one. But it is definitely reported in the literature, and you are absolutely correct if the patient responds, and particularly with the steroids. But at this juncture, what Somen has pointed out, that is most, whatever is our documented, you can only document this finding, but the serial VP is of utmost importance.
I can understand. So I think we are almost not running late. We are quite late. So I would like to thank all of you and for today's program and make it a grand success for all of your contribution today's here. So I think this is one of the very most interactive session what we had till now. I think Dr. Arup Chakraborty was advising for the same like this kind of programs in future. So let's see what we can.
We need to give a big hand for Rupak for organizing this program. And Arupda also, he advises this sort of meeting. So thank you. It's very, very useful meeting.
Yeah.
And thank you for the audience. All of you have come.
No, and there is one more request to Shovik-da. You have listened all the cases, so please compile a literature of all of them and pass it on to me. I will circulate into the SWB groups for everybody's knowledge to enrich.
We have to give big thank to Songita because she had made up the time.
Yes, she needs a big round of applause again because she has finished it quite well. Okay, bari jeta hobe sei jonne taratari. So thank you all and please join us for the dinner upstairs.
19th floor.